Today we are going to talk about lameness in horses, an abnormal stance or gait caused by pain, restriction, weakness, or neurologic disease. A horse may shorten its stride, land toe first, resist turning, nod the head with forelimb pain, or hike the pelvis with hindlimb pain. Sudden non-weight-bearing lameness, a penetrating foot wound, an unstable limb, a hot swollen joint, or strong digital pulses is urgent. A useful mnemonic is hoof steps. It recalls hoof abscesses and sole bruising. Osteoarthritis such as ring bone and bone spavin, osteochondrosis and bone cysts, fractures, faulty hoof balance and poor shoeing, flexor tendon and suspensory injuries, trauma to joints and tendon sheaths, endocrinopathic laminitis from equine metabolic syndrome or PPID, navicular disease and penetrating wounds, and septic arthritis or neurologic mimics. The anatomy explains the signs. Interlocking dermal and epidermal lamellae suspend the coffin bone inside the hoof capsule. In laminitis, these attachments weaken, allowing rotation or sinking. The navicular bone, navicular bursa, deep digital flexor tendon and supporting ligaments form the podotrochlear apparatus. The navicular bone distributes pressure as the deep digital flexor tendon turns toward the coffin bone. The superficial digital flexor tendon stores elastic energy and supports the fetlock, while the suspensory ligament limits excessive fetlock extension. In a healthy joint, smooth cartilage and synovial-fluid minimize friction. Repeated overload and synovitis increase prostaglandin E2, damage cartilage and stimulate subchondral bone remodeling. Because adult cartilage heals poorly, chronic disease can cause cartilage thinning, osteophytes, joint capsule fibrosis, and reduced motion. Horses with osteoarthritis may start stiff, loosen during light work and become lame again after harder exercise. A hoof abscess forms when bacteria enter through a crack, white line defect, nail tract, or sole puncture. Pus becomes trapped beneath rigid horn, causing severe pressure and dramatic single-limb lameness. Tendons and ligaments fail when repetitive strain exceeds repair capacity. Collagen fibers tear, followed by hemorrhage, edema, and inflammation. Healing tissue is initially weaker and less organized than normal tendon, so a horse may look comfortable before it is ready for galloping, jumping, or sharp turns. Navicular syndrome may involve navicular bone remodeling, deep digital flexor tendon degeneration, navicular bustle inflammation, or injury to the impar and collateral sesamoidean ligaments. Septic arthritis is especially urgent because bacteria and inflammatory cells release enzymes that rapidly destroy cartilage. Affected horses may have severe lameness, joint effusion, heat, pain on flexion, and sometimes a wound communicating with the joint. During examination, the veterinarian watches the horse walk and trot in straight lines and circles, palpates the limbs, checks hoof heat and digital pulses, applies hoof testers and may perform flexion tests. Diagnostic nerve blocks are usually placed from the foot upward. If local anesthetic markedly improves the gait, pain has been localized to the desensitized region, although anesthetic diffusion must be considered. A joint, tendon sheath or bursa may then be blocked more specifically. Radiographs are useful for fractures, osteophytes, subchondral sclerosis, bone cysts, coffin bone rotation and navicular bone abnormalities. Ultrasound can show tendon enlargement, disrupted fiber alignment, hypoechoic core lesions, suspensory injury, and tendon sheath fluid. Suspected septic joints require synovial-fluid analysis for cell count, protein, cytology, and culture. MRI is especially useful when foot pain is localized but radiographs do not explain it. It may reveal deep digital flexor tendon enlargement, longitudinal splits, fiber disruption, navicular bustle effusion, collateral ligament injury, impar ligament damage, cartilage defects, and bone edema-like change. Findings must match the examination and nerve blocks because not every abnormality causes pain. CT creates cross-sectional images that can be reconstructed in 3 dimensions. It is particularly useful for incomplete fractures, cortical fissures, small fragments, subchondral defects, cyst-like lucencies, sclerosis and articular surface irregularity hidden on radiographs. CT defines fracture direction and extent well, while conventional CT is less sensitive than MRI for soft tissue unless contrast is used. Treatment must address the cause rather than merely hide the limp. A routine hoof abscess is drained through the smallest safe opening, protected with a clean bandage or boot and monitored until sound. A deep puncture near the coffin joint, navicular bursa, or deep digital flexor tendon is an emergency. Acute laminitis requires treatment of the initiating endocrine, gastrointestinal, or systemic disease, pain control, restricted movement, supportive bedding and therapeutic farriery. Acute tendon injury is initially managed with controlled rest, cold therapy, and compression when appropriate. Rehabilitation progresses from hand walking to longer walking, trotting, and discipline-specific work according to repeated examinations and ultrasound. Recovery often takes many months because collagen maturation continues after swelling and obvious lameness disappear. Premature loading greatly increases re-injury risk. Phenylbutazone, flunixin, meglumine, and firocoxib are NSAIDs that inhibit cyclooxygenase enzymes and reduce prostaglandin production. COX-2 becomes more active in inflamed tissue and helps convert arachidonic acid into prostaglandins such as prostaglandin E2, which sensitizes pain fibers and contributes to heat, swelling and pain. COX-1 has housekeeping roles in gastrointestinal protection, platelet function, and renal blood flow, although COX-2 also has normal functions in the kidneys. Firocoxib preferentially inhibits COX-2, aiming to reduce inflammatory prostaglandins while sparing more COX-1 activity than non-selective NSAIDs, but it is not risk-free. Dehydration, kidney disease, gastric ulceration, and combining NSAIDs or corticosteroids increase toxicity. Firocoxib is labeled at 0.1 mg per kilogram orally once daily for up to 14 days. Phenylbutazone is commonly used at about 2.2 to 4.4 mg per kilogram, while flunixin is labeled near 1 mg per kilogram once daily for up to 5 days. A veterinarian must direct product choice, route, and duration. For selected inflamed joints, a veterinarian may inject triamcinolone or betamethasone. These corticosteroids enter cells, bind glucocorticoid receptors and alter gene transcription, reducing cytokines, inflammatory enzymes, and prostaglandin production. Hyaluronic acid may support synovial-fluid properties and reduce synovial inflammation. Doses depend on the joint, formulation and horse. Corticosteroids should not be injected into a septic joint, and direct injection into damaged tendon is avoided because they can weaken collagen repair. Platelet-rich plasma, or PRP, is made from the horse's own blood by concentrating platelets into a smaller volume of plasma. When activated, the platelets release growth factors from alpha granules. Platelet-derived growth factor promotes cell migration and proliferation, transforming growth factor beta influences collagen and extracellular matrix production, and vascular endothelial growth factor supports new blood vessel formation. The fibrin network provides a temporary scaffold for repair cells. PRP is intended to encourage more organized tendon or ligament healing, not to replace missing tissue or act as a stem cell treatment. It is usually injected into a defined lesion under ultrasound guidance and must be paired with controlled rehabilitation. Results vary because preparations differ in platelet concentration, leukocyte content, and activation method. Prevention means keeping workload within the tissue's ability to adapt. Hooves should be trimmed or shod regularly with attention to balance, breakover and heel support. Conditioning should increase gradually, and footing should provide traction without being excessively deep or hard. Maintaining appropriate body condition and controlling insulin dysregulation or PPID reduces laminitis risk. Feet and limbs should be checked daily for heat, swelling, stronger digital pulses, wounds or new sensitivity. After injury, return to work should be based on the diagnosis, repeated examination and follow-up imaging rather than the calendar alone. Anti-inflammatory drugs can make a horse appear sound before the tissue has regained strength. Early localization, diagnosis-specific treatment, corrective farriery and controlled rehabilitation offer the best chance of a comfortable return to work with less risk of recurrence. If you would like to donate to our video and game development or suggest topics, reach out to dogtoursgame@gmail.com.